hard when you have to just talk to the screen and can't see people. You really wonder. Okay, so thank you for posting that link for the students. So we're going to talk about some fundamental concepts, as I said. So again, hopefully that'll make it a little bit of an easier afternoon after all of that med surge these last few days. And we're also going to talk about, this afternoon, we're going to talk about the actual NCLEX exam, what you're going to expect to see. And we have a bunch of questions students have asked us in the past about the exam. So we're going to share those questions with you to give you some information about the exam itself and what to expect, et cetera, and see if you guys have any questions. So we'll get started. And I think there might be about 20 slides in here or so. So we'll show you the first slide. And we have a question here. So that the nurse caring for a newly admitted client notes that the healthcare provider has prescribed a medication dose that is twice the amount that the client reports taken prior to admission. Which is the appropriate nursing action? Consult with the healthcare provider, administer the medication as prescribed, administer half of the prescribed dose, question the client regarding the accuracy of the reported dosage. Great job, you guys. 96% said to consult with the healthcare provider, and that is absolutely the correct answer. We do have some responses for option 4, to question the client regarding the accuracy of the reported dose, but the healthcare provider prescribes the med, if you read the question, and the client and what the client reports is taken prior to admission. So you wouldn't want to question the client again. I mean, maybe you would, but it is not the most appropriate or best action for the options provided. And what you need to remember is that with something like this, whenever there is an issue in the clinical setting, and you could see questions like this on NCLEX, whenever there is a question in your mind about the medication dose, you always stop in your tracks and you find out what is correct. And we do need to go to the healthcare provider. We have to go to the prescriber of that medication dose to confirm and verify. Okay. All right. If there are no questions, we'll move on. A client is brought to the emergency department after being hit by a car. The name of the client is not known. The client has sustained a severe head injury, multiple fractures, and is unconscious. An emergency craniotomy is required. With regard to informed consent for the surgical procedure, which is the best action? Transport the victim to the operating room, obtain a court order for the surgical procedure, call the police to identify the victim and locate the family, ask the emergency medical service team to sign the informed consent. Okay, great job. The answer here is option 1. We would transport the victim to the operating room. And let's just take a quick look at this. No one selected option 2 or option 3. So that is excellent. We know that obtaining a court order, which sometimes does have to be done in some situations, you note here in the question, an emergency craniotomy is required. So if it's an emergency, you would transport the victim to the operating room or wherever, and do the procedure or the surgical procedure or whatever procedure it might be. We can do that in an emergency situation if we don't know the victim name, or if we aren't able to identify that victim and locate a family member. And obtaining that court order, asking the police to identify the victim and locate the family is just going to take too much time. And 4, asking emergency medical services team to sign the informed consent. And I wanted to mention this because some of you selected that answer. No, they cannot sign an informed consent for this client. The client is supposed to sign the informed consent unless they are unconscious, which is the case here, or they're not mentally competent to be able to do that, in which case the next person who is in charge or in order of that for that patient would be signing the informed consent. So as a nurse, our responsibilities, we can witness the client signing an informed consent. We can make sure that the client understands everything on it. But if the client has questions about any procedure or surgical procedure or any other kind of procedure, then really the person who is performing that procedure needs to come and talk to that patient. Okay, but we can witness them signing it as long as they understand everything on that. And one other point I wanted to bring up is about the non-English speaking client. Okay, if we have a client where there's a language barrier, then we always, and this will be the answer to the question, you always get the agency interpreter. You do not use a relative to interpret for you or translate for you. You do not use a housekeeping person who happens to be around and can speak the patient's language. You must go through the proper channels and get an agency interpreter for that. So just keep that in mind in case you see a question like this. Okay, if there are no questions, we'll move on.
Can I ask a quick question? I don't know if this would ever come up on NCLEX or anything, but what happens, say we see that they have a Jehovah's Witness or something, like a bracelet on or something like that?
In terms of informed consent?
Yeah, like, so if the person needed an emergency craniotomy, and I know like it has to do with blood transfusions and stuff, right? But
Yes.
like, what if, they're going to have to go into surgery? Would we just not put blood transfusion or blood on hold for them or anything?
Well, what would happen to what would be if the surgeon is able to speak to the patient, then that would all be determined. The patient will probably refuse any blood. And so the surgeon would have to explain to that person the risks of what could happen. They have to explain this anyway, but the risks even further with this person, the risks of what would happen if blood is needed and they're not able to give blood because there is no consent to do so.
But what if they're unconscious is my question.
Okay.
Like, is what I mean, yeah.
It would be the next of kin. It would be the husband or other significant other person who is the next of kin to that person would be able to give consent or not consent for the blood. And I'm just going to tell you about a quick situation that I heard about just last week about a young woman who was 30 years old, okay, who went in for a hysterectomy. She was Jehovah's Witness. And she came out of surgery, and post-operatively on the nursing unit, she started to bleed and had uncontrolled bleeding and became unconscious, and the husband would not agree to the blood transfusion that this 30-year-old beautiful girl needed, and she died. So, they're very, very strict in that religious faith about transfusion, blood transfusions. So I just wanted to share that with you, but yes, it would be the next of kin if that person was not able to give consent. Does that answer your question?
It does. I was just curious, because how this one, it was phrased as like you didn't know who the person was. So, and yes, there wasn't an next of kin. So I just didn't understand what we would do in a situation where it was just like this, but they had a Jehovah's Witness bracelet and stuff like that. I just wasn't sure on how we would
Yeah, that
do that.
is, okay, so I get what you're asking now. If they had a Jehovah Witness bracelet on, I think that they would need to get surgical residents, surgical people in that, you know, were in charge, and decisions would have to be made. They may have to get some emergency court order if they had no idea. Usually, if we are unable to identify a victim or locate a family, normally the procedure is that we need to do what we need to do to save that patient. So that's a very interesting question. And
Thank
so,
you.
decisions would be made at that agency in terms of this, if there was the Jehovah Witness bracelet on. If they didn't know the person was Jehovah Witness, they would give blood and just have no idea. But we have to do what we need to do if we can't get in touch with anybody. Now, you won't see a question like that on NCLEX because that's
Okay.
much too.
I wasn't sure, so.
Oh, no, I'm really glad you brought that up because it just generated a great discussion here of clinical situations that you will encounter when you're out there. But you won't have anything that complex on NCLEX in terms of, okay, they've got a bracelet on, what are you going to do? That won't be on there. There may be concepts related to Jehovah Witness, knowing that we cannot give them blood transfusions unless we ask, but that's with the conscious patient. So, or a husband is there, which happened in the case that I heard about just last week. And so hopefully that helps. Any other questions about that? No? Okay, great. The nurse is caring for a client who is on airborne precautions and notes that the client is scheduled for an MRI test. Which is the best nursing action for preparing the client for the test? Plan to have the MRI performed at the bedside. Ask that the MRI department be called to tell technicians in the department to wear masks. Place a surgical mask on the client for transport and for contact with other individuals. Ask that the MRI department be called to tell the technician that the test will have to be delayed until the airborne precautions are discontinued. So look at this. It's airborne precautions. It's an MRI test. And we're looking for the best nursing action. And when you see that word best, it could mean that one or more than one options are correct, but you have to think about what is best here. That's where it gets difficult on NCLEX with the prioritizing piece. All right, well, 75% of you selected option 3, which is the correct answer. That's absolutely excellent. Yes, we definitely place a surgical mask on the client for transport. MRIs cannot be done at the bedside. The CTs, MRIs, they have these huge machines, and there isn't any way that they could bring an MRI machine to the bedside. So that's why option 1 is incorrect. Now, we may call the MRI department and let them know so that they can protect themselves better than they normally would if they know that a patient is coming that is on airborne precautions. So we would do that. But option 3 is definitely the best response here because you're going to be transporting a patient through hallways, et cetera, and in elevators. And if they're on airborne precautions, we don't want any transmission of any infection. Okay, and 4, that's clearly wrong. We would not delay the test. If the test needs to be done, we wouldn't do that. That is not within our realm of responsibility as a nurse. And so that's kind of out of the question there. Okay, any questions about that? Okay, and the other thing is just be sure that you are clear about exactly what airborne precautions are and what contact precautions are and what droplet precautions are. And I mean, that's just really important because especially with all of this COVID, information that's out there and all of this COVID that we've had to deal with in hospitals and in the community, et cetera, it's just really important. You're likely to see questions on precautions and how you would best protect yourself. Okay. All right, next question. Okay, these are basic questions too, but let's take a look at them. The nurse employed in the ambulatory care department hears a client in the waiting room call out, "Help, fire." The nurse rushes to the waiting room and finds the wastebasket on fire. The nurse should take which immediate action? Confine the fire, extinguish the fire, activate the fire alarm, remove clients from the waiting room. Okay, excellent. Option 4 is your correct answer. 81% of you selected that. Yes, remember the acronym RACE, R-A-C-E. So remove your patients from the waiting room or wherever it is, and then you would activate the fire alarm. You would confine the fire, and then you would extinguish the fire. So keep those concepts in mind whenever you see a question like this, okay, that relates to fire safety. And all of that information about safety, electrical safety, fire safety, those are the areas you want to review just in case you get a question. I think they're on page 171 in the comprehensive review book. So you can take a look at that and just review those concepts. Okay, if there are no questions, we'll move on to the next one. Okay. The healthcare provider prescribes 1,000 mLs of 0.9% normal saline to run over 8 hours, and the drop factor is 10 drops per ml. The nurse adjusts the flow rate to run at how many drops per minute? And this question tells you to round your answer to the nearest whole number. So why don't you just take a moment and figure that out? We'll see what you come up with. Okay, did you figure that out? So Devin, if you push enter, will the answer show up there or is it on the next screen? I can't remember.
This slide does not have an answer attached to it. I'm assuming that we're, making them bend their mathematical minds to this.
Okay, so on the end, the answer to this question, well, if you calculated this question, it would come out to 20.8 drops, and we know we can't calculate 0.8 drops. So you would round that to 21 drops per minute. Now, we know in clinical that most institutions, agencies use controllers for any IV that we're running into a patient these days. But there are remote hospitals out there that don't have the luxury of having these controllers, IV pumps and controllers. So for that reason, since this is a national exam, NCLEX may present a question on either a drug calculation, which I think we'll see in a few minutes, or an IV flow rate, or on calculating a heparin drip drops per minute, or an insulin drip drops per minute. So if you look in the comprehensive review book, there is a chapter on medication calculations. And if you can practice those questions at the end of the chapter and be proficient at those, you're going to be all set. Also on your Evolve site for the comprehensive review book. If you go into alternate items and you click fill in the blanks, you will get hundreds of these practice questions. So if you're not real clear about calculating IV drip rates, that would be what we recommend that you do. You will have a calculator, an on-screen calculator on NCLEX, so you'll be able to use that calculator to help you with these types of questions. You will also be receiving a whiteboard of sorts that you can do calculations on as you receive these questions. So you're going to have a lot of supports when these questions come up. But my point that really important point that I want to make is follow the directions. If it doesn't say to round, then you don't round. If it doesn't say record with 1 decimal point, you have to do what the question says. Okay, so just read every word, read it carefully. Sometimes we tend to do these kinds of calculations in our head, which is great, but I would recommend that even if you do something in your head, do it on the calculator just to be sure. Get credit for the question. Okay, so your answer is 21 drops per minute. So your formula would be your total volume times your drop factor. So 1,000 times 10 divided by the time in minutes. So it would be 8 hours. So you would have to multiply 8 hours times 60 minutes in an hour and divide it by 480. Okay. And that's how you would figure this one out. Any questions? If not, we'll move on to the next. Okay, so here's a question on a medication calculation that you might see. So the healthcare provider prescribes meperidine, 40 milligrams, and the medication label states meperidine, 50 milligrams per ml. So how many mLs should the nurse prepare to administer to the client? So just take a minute and try to figure that out. Okay, so for here, your answer would be 0.8 mLs, okay? And again, if you had difficulty with this, we highly recommend you go to that chapter in the book and practice some calculation examples. Now, this question does not say to round anything or do anything. So you just, whatever you get for your answer, that's what you would type in. This answer is 0.8 mLs. You can type in on NCLEX 0.8. You don't have to type ml because it's always going to be there for you. Whatever a unit of measure it is always going to be there for you. You only have to type the number. You can type 0.8 and you would be correct on NCLEX, or 0.8. They will accept either as long as you have that decimal point there, because if you typed in 8, it would clearly be incorrect. Okay, Demerol, we talked a little bit about that. I think that came up in a question yesterday, I think. And because I think we were talking about bradycardia and tachycardia. The big thing with Demerol, as we mentioned yesterday, that we think that if you were asked about this drug, and again, they're not using it so often anymore because of the risk of seizures, we think that they would probably focus on urinary retention. That's quite specific to this medication. I mean, all opioids can cause that, but very specific to this one. And then again, with your morphine, focus on respiratory depression, and your codeine, constipation, and think about those things, look those things up. Okay, so let's see what we have next on the screen here. Okay, we have another calculation. The healthcare provider prescribes potassium chloride 20 MEQs, and it's elixir. And the medication label states potassium chloride 40 MEQs per 15 mLs. So how many milliliters should the nurse administer to the client? So you would calculate that. I'll give you a minute to do so. Well, 15 seconds, maybe 20 seconds. Okay, so if you calculated that out, your answer would be 7.5 mLs. So you would type in 7.5, okay? Potassium, I'm not sure, I didn't hear all of Lisa's presentation yesterday, but potassium can come as an elixir. So that's a liquid med, and it has a terribly horrible taste. So the patient could mix that in orange juice if orange juice is acceptable in their diet. And potassium chloride also comes as tablets, but the tablets are very large, and many people do have difficulty swallowing those. So just a point to keep in mind. And we can give potassium chloride by IV, always through an IV pump, always. Okay. When you have your potassium chloride, usually it comes mixed from the pharmacy. Sometimes we have to mix it, but in most hospitals, it's all pre-mixed for you. Just remember that potassium settles in the bottom of the bag. So you want to, just mix the bag a little bit back and forth so that it isn't all sitting at the bottom of the IV bag going into the patient, all of the potassium at once, which would not be a great thing because of dysrhythmias. But again, it would also it would burn. Potassium can burn, the intravenous site. So we want to remember that about that drug too. Okay, let's see what's next. Okay, the nurse notes that a client's intravenous site is cool, pale, and swollen, and the solution is not infusing. The nurse interprets that which complication has been experienced by the client. This is a typical question that you might see, or you might see the actual condition, like phlebitis may be in the question, and then the options might be the signs and symptoms. So it could be, set up either way. So is this phlebitis, infection, infiltration, or thrombosis? Okay, 89% of you said infiltration, and that is definitely the correct answer. Some of you selected phlebitis, and some of you selected thrombosis, and no one selected infection. So that's great. So with infiltration, what you want to remember, with infiltration, the IV fluid actually has seeped into the tissues because the IV catheter is no longer in the vein where it's supposed to be. So that's why the word cool will give you the tip that it's an infiltration. Phlebitis, we're going to see warm and red, okay? Thrombosis, we might see warm and red, but it's going to feel hard, kind of cord-like, so that would be a thrombosis. Infection, we know signs of infection, redness around the site, would be our most typical finding with that. So what would we do if infiltration occurred? Likely to be asked about this. If there's an infiltration, that IV needs to be removed and restarted at another site, probably the other arm, not in that same vein, and maybe above that vein, but not below it. Phlebitis, same thing. That needs to be, IV needs to be removed, restarted. And with phlebitis and thrombosis, we need to let the physician know about that. Okay. So those are just some things to look at and what you would do, know what you would do if those things happened. And there is in the book, there is a chapter on, IV solutions, and it will give you all of these complications and tell you what you need to do as a nurse if they occurred. And their signs and symptoms are there. Okay, let's see what we have next. A client returns from the operating room following a craniotomy. On data collection, the nurse notes that the vital signs are BP 112/72, pulse is 82, respirations are 16. Preoperatively, the vital signs were 124/78, pulse 74, respirations 20. So which action should the nurse take? Call the surgeon immediately, shake the client gently to arouse, recheck the vital signs in 15 minutes, or position the client in Trendelenburg, place the client in Trendelenburg position. Okay, excellent. 89% of you said that you're going to recheck the vital signs in 15 minutes. A few of you said to call the surgeon, and some of you said to call to place the client in Trendelenburg. No one's going to shake the client gently to arouse, and that's great. We're not going to shake the client. We don't want to do that, especially if they've had a craniotomy. Okay, and that the answer here is 3. The 4, since we're talking about craniotomy, you never would place the client in a Trendelenburg position because any head injury, any head surgery, anything like that with the head, you don't want to do that and place them in Trendelenburg because our biggest concern is intracranial pressure. And so if blood flows into that brain, because we put them in Trendelenburg, they're going to end up having intracranial pressure. The pressure will build up, and we're going to have a serious condition on our hands. So the answer here is 3, calling the surgeon immediately. Whenever you get a question like this, look at the vital signs. They're showing you actually kind of trends or changes. And if you look at the vital signs pre-op, they're all within normal range. 124 might be just a tiny bit high, but not really. And pre-op, we expect some anxiety in that person. And so the blood pressure would be up a little bit. And that is a normal thing. So we don't need to be concerned about that. And if we look at post-op, they're all in normal range. So everything's normal here. So we don't need to be calling the surgeon immediately. Okay, we would recheck and we would monitor the client. Okay, so great job on that. Next question. Okay, the nurse receives a telephone call from the post-anesthesia care unit stating that a client is being transferred to the surgical unit. The nurse plans to take which action first upon arrival of the client? Assess the patency of the airway, check tubes or drains for patency, check the dressing to assess for bleeding, or assess the vital signs to compare with pre-op measurements. Great, 93% of you have said assess the patency of the airway. If the person does not have a patent airway, nothing else at all matters, okay? And so, yeah, do we want to assess the vital signs? Some of you selected that to compare with pre-op measurement. Yes, we do, but we would always check the patency of the airway first. And, you know, I know as a surgical nurse, patient would come back from the OR and I would glance up at their IV to make sure it's not running like crazy and it's running okay. And, you know, we put them back into bed and I'd take a peek at the dressing. You know, I do a lot of those things. A lot of these things are done at the same time, sort of simultaneously. But patency of airway, remember, airway is always first. And again, nothing else matters if they're not breathing and their airway is not patent. Any questions about that? Okay, go on to the next. See what we have next here. Okay. When performing a surgical dressing change to a client's abdominal dressing, The nurse notes an increase in the amount of drainage and separation of the incision line. Okay, so just kind of picture that in your mind. The underlying tissue is visible to the nurse. The nurse should implement which action in the initial care of this wound? Apply a betadine soaked sterile dressing, leave the incision open to the air to dry the area, irrigate the wound and apply a sterile dressing, apply a sterile dressing soaked with normal saline. Okay, so we have ones, we have threes, and we have fours, and your answer here is 4. Apply the sterile dressing soaked with normal saline. That is your answer. You would not irrigate that wound. So remember, I think Angela talked about this yesterday or the day before. When you see an answer that has the word "and" in it, like option 3, irrigate the wound and apply a sterile dressing. Yes, sterile dressing is something we're going to do, but both sides of that option need to be correct. Irrigating the wound is not correct. So that's why we would eliminate option 3, and no one is going to select option 2. We would not leave it open to air to dry the area because we have an open area and we have underlying tissue exposed. A betadine soaked dressing is going to hurt, really hurt. That is going to burn like crazy. So we wouldn't want to do that. If we take a look at the next slide, this is what is happening to that patient. That patient actually had a wound dehiscence, which is on the left side. So the wound opens up, underlying tissue shows. So we have that separation at the suture line. Whenever that happens, the patient will usually say to you, "Oh, I feel like something popped in my incision." Just felt like a pop to them. If you take that dressing down, which you would do to take a look at it, and you saw this, you would elevate the head of the bed slightly to like 15 degrees or so, because that way there, if the client was lying flat, causes pressure on that incision and it'll make it split open even more. And we don't want the picture on the right to happen with the bowel popping through or any internal organs popping through. That's evisceration, and that's a surgical emergency. You would apply the saline soaked dressings. You'd contact the surgeon immediately. Evisceration is a surgical emergency. That person would go to the OR and have that bowel replaced. We would never try to replace or push organs back into the wound. And I've seen questions like that out there, as an option, place the organs back into the wound gently. No, we would contact the surgeon, elevate the head of the bed, saline soaked dressings on the wound, contact the surgeon. And while you're doing all of that, somebody can contact the surgeon for you. You would never leave the client. Okay. Actually, you would never leave a client in any emergency situation. You'd always get somebody else to contact the surgeon or doctor for you. Okay, so those are the difference between the wound dehiscence and evisceration. And if you ever saw that happen, you need to do something immediately. They're both emergency situations. Any questions about that? Okay, then we'll move on. Okay, and I know Lisa talked about chest tubes yesterday. We'll just talk about them just a slight bit, because I know she did go over them, and she did talk about sometimes some patients will come back with 2 chest tubes, one in the upper area, one in the upper drain and the lower drain. The upper one would drain air, whereas the lower one would drain any fluid that has accumulated that they're trying to drain out of there. And that's easy to remember because fluid is always heavier than air, so fluid would drop. So that's why the lower one would drain the fluid, and air rises. So that's why the upper one would drain air. So just a little tip to kind of help you with that. So let's see. I think on the next slide, we have a picture of, yeah, okay. Usually the patient will have a 3-chamber chest tube drainage system. And there's 3 chambers. There's a suction control chamber, there's a water seal chamber, and there's a drainage collection chamber. And let's just talk quickly about each chamber. And again, I know Lisa talked a little bit about this yesterday. So let's talk about the drainage chamber first, which you can see there in the picture. So the drainage chamber collects the drainage, and that big yellowish colored tube from that drainage collection chamber will be going to the patient or coming out of the patient, whichever way you want to, call it. And drainage will come into that chamber, and this is not like a Foley catheter where you empty it at the end of the shift. You never open or disrupt this Plurivac drainage system or chest tube drainage system. So you would monitor the amount of drainage per shift or per hour, depending on the status of the patient. And you'd place a little piece of tape with a time and date as to where the drainage was. Perhaps at 3 p.m. you're leaving your shift, and you would put a little piece of tape, 3 p.m. and the date. So the next person coming on would know and be able to monitor how much output that patient is draining, and the status of it. So that's your drainage chamber. And depending on the status of the patient, also, if the patient is immediately post-op, then yeah, you might see some bloody drainage, but you don't want to see an increase in any drainage in that patient. Immediate post-op, that patient may drain 100 mLs an hour, but it will start to decrease or should start to decrease. And if it doesn't, then that's a concern, okay? Your suction control chamber is what it says, suction control, and it's attached to suction. And what you want to see in there is gentle bubbling. You will always see gentle bubbling in the suction control chamber, because that means it's working and it's helping to pull that air, helping to pull that fluid out of that patient, okay? So that's pretty simple. And your water seal drainage that you can see there, you're going to see fluctuations, a rise and fall of fluid in that chamber as the patient breathes in and out, okay? And that's what you want to say in a patient who has had a chest tube inserted. Now, if you don't see fluctuation in that chamber, it could mean a few things. It could mean that maybe it's time for that chest tube to come out, that everything is sealed up in that pneumothorax has resolved or whatever. And what they will do in that case, you would notify the physician if fluctuation stops, if it's not caused by something else, which I'll talk about in a minute. But if you see fluctuation is stopped, you're going to take a few interventions, and then you're going to call the doctor, because they'll probably have a patient go for a chest x-ray to see if that lung is all healed up. And if it is, then that chest tube would be removed, okay? You wouldn't remove it, but somebody would be called, resident or whomever, hospitalist, to remove the chest tube based on the chest x-ray result. Now, if you see that there is no fluctuation in that tube, a couple of things you would do before you go call the doctor would be, you'd make sure the patient isn't lying on the tube, that there's not a kink in the tube, that something's stopping that movement that we want through that chest tube system to help drain air and fluid from that patient. But if there are no kinks, nothing is cut off, the patient's doing fine, not having any trouble breathing, it's been 2 days, 3 days post-op, then the likely reason the fluctuation has stopped is the lung has healed up. So hopefully that information, so somebody's adding a little trick here. So let's see what it says. I can only see part of it. Angie, can you see that?
So I can just explain it really quick. It was
Sure.
just that in the water seal chamber, because you don't want to see the continuous bubbling. Just
Correct.
imagine you go to the store and you're buying a Coke, like a bottle of Coke. You wouldn't want to, it's sealed. You wouldn't want to see that continuously bubbling. So it's just a little trick that I had learned.
Yes, now we did say we wanted to see gentle
Intermittent,
bubbling
yeah.
in the suction control, but in the water seal drainage, you don't want to see continuous bubbling, because if there is continuous bubbling, then it could mean an air leak somewhere in that system. And we don't, you know, if there's an air leak, we need to do something about it. We need to find out if the air leak is in the system, inside the client, an air leak in there. And you might occasionally see a little bubbling in the water seal, an intermittent bubble here and there. That's okay. That's okay. Especially if it's draining air, you might see an intermittent bubble, but that continuous bubbling is not something we want to see in that water seal chamber. So thank you so much for that tip. That's great. All these tips really help remember things. And so thanks so much for that. Any questions about that system? Okay, well, if any come up, just let me know, and let's see what the next slide is, because I was going to talk about this, but I didn't want to give the answer away. So the nurse is assisting the healthcare provider with the insertion of a chest tube. The nurse notes fluctuation of the fluid level in the water seal chamber after the tube is inserted. Based on this observation, the nurse should take which action? So this should be pretty easy for you. Assure that suction is turned on, reinforce the occlusive dressing, encourage the client to deep breathe, document the accurate functioning of the tube. Okay, great. 94% of you selected the correct answer. You want to see the fluctuation, especially after it's just been inserted. So we would want to see that. And if we do, then we know it's accurately functioning. Assuring that the suction is turned on will not affect the fluctuation in the fluid level. Okay, so there's no effect on that in terms direct effect that you would see. Okay. So that's why option one is incorrect, which some of you answered, and no one answered 2 and 3. So that's great. Okay, we'll go to the next question. All right, the nurse is caring for a client with a chest tube who accidentally disconnects the tube from the drainage system while trying to get out of bed. The nurse should take which action first? Okay. So read these carefully, because you are definitely going to have chest tubes on your exam. And I highly recommend that you go to the section on chest tubes. I think it's in chapter 70 now, and read all about all of these chambers, what to expect in each chamber, what you would do if it disconnected. Okay, so the tube disconnected from the drainage system. And the other thing they're going to ask you is, the tube pulled out of the client's chest. All right. Those are the two situations you really want to know about. So in this situation, the chest tube accidentally disconnected the tube from the drainage system. So are you going to replace the chest tube, place the client in a prone position, immerse the end of the tube in sterile saline, place a sterile dressing over the end of the chest tube? Okay, excellent. 91% of you selected option 3, which is definitely the correct answer. If that chest tube disconnects from other patient, Remember, we don't want that person, our drainage system is functioning as our water seal and preventing any further pneumothorax in that patient. So you would definitely immerse the tube into some sterile saline, and that sterile saline, that fluid is going to act as the water level fluid for that chest tube system until you can get help. And you would definitely stay with this patient. Someone would get another chest tube drainage system, and if that was necessary, or the tube would get reconnected depending on where the problem occurred. Placing a sterile dressing over the end of the chest tube sounds like a very good option, but that would not be your initial action at all. You would put that end of that tube into the saline to act as your water seal. So that would be your action that you would take with that. Okay, let's see if we have another chest tube question, because there's one, no. Okay, so let me just talk about, we'll go back to that previous question if we can, Devin. Okay, so the other thing that I mentioned that they'll ask you about is what happens if it pulls out of the client's chest, okay? Which can happen. The patient is not careful, rolls over, too forcefully, and it pulls out of the chest. You would put an occlusive dressing on that chest immediately, and you would get help. You'd stay with the person, monitor their respiratory status, have somebody get help. And the one problem with putting an occlusive dressing over a chest tube opening is the possibility of pneumothorax, and the possibility of that person having some respiratory distress and having a buildup of fluid in their chest, etc. So stay with that person, monitor them. If they start having respiratory distress after you put that occlusive dressing on and you're waiting for people to come to help, just lift up one corner of that occlusive dressing, and that will allow some equilibrium of air into that patient's chest and out, okay? So that would be your action. Your occlusive dressing, stay with your patient, let somebody get help. Patient starts having trouble breathing, just lift up the corner edge of that dressing, occlusive dressing that you have put on that patient, okay? And I think that's it with chest tubes, unless you have a question about anything else with that. Okay, now we'll move on. Okay. The nurse has a prescription to give an antacid to a client through a nasogastric tube that is connected to wall suction. The nurse plans to take which action to perform this procedure correctly? Position the client supine to assist in medication absorption, clamp the NG tube for 30 minutes following administration of the medication, aspirate the NG tube following medication administration to maintain patency, adjust the suction to low intermittent setting for an hour after medication administration. So let's see what you do with that. Okay, so 50% of you selected option 2, which is definitely the correct answer. Clamp the tube for 30 minutes following administration, because we want that medication to absorb, okay? And if you aspirate the tube following med administration, you're just pulling the med out. So why bother give it? And same with 4. If you put adjust suction to low intermittent suction for an hour, it's just going to suck that medication out. That's why options 3 and 4 are incorrect. Option 1, placing the client supine, is going to could cause a problem with aspiration. So we don't ever really want to put a person who's receiving anything through an NG tube in a supine position. We need to keep the head of their bed elevated to prevent any aspiration. And the other things with NG tubes, so that's the issue with the medications. The other thing with an NG tube, you always want to check placement of NG tubes before you go instilling anything. And you always want to check for residual, which is fluid or food that is still in the stomach. Usually the agency will have a magic number that you want to go by. If the residual is higher than so much, then they want you to hold the feeding and wait an hour or whatever. Usually, if it's greater than the amount that you're giving every hour, is usually another guideline. So I don't think that NCLEX is going to ask you about specific amounts of residual, but they're going to ask you about the concept of knowing that you need to do something if there's a large amount of residual, larger than they're getting per hour, okay, which would be to hold it and reassess later. Okay, I think on this next slide, I think this might be our last slide, I'm not real sure. It just is showing you the description of bolus feeding or giving meds to the patient through the NG tube. And it's the bottom picture there shows you the solution that's going in through the NG tube, how it's going down through the esophagus and into the stomach, and how that NG tube might sit. And then we have our feeding pump, which you're probably pretty familiar with. Okay, now was that our last slide, Devin?
This one's the last one.
Oh, okay, and here you go. Some pictures of the checking the residual, just a little better picture of checking residuals and administering the meds through the NG tube. Okay. Okay,
All right, so that's the end, right?
that's the end.
Awesome. Thank you so much,
They
Linda.
did great. Oh, you're welcome.
They did really good. You guys, do you have any questions on the fundamental section? Nothing, no questions? All right, so I have created a new Zoom link for our last session. I'm gonna post it here in the chat. And Devin, just so you know, I did go ahead and add polling to the few questions that we have in this last section. So if you guys want to hop over to this link, we'll get started at, if you want to go take a quick bathroom break, we can get started at maybe 5 after the hour and we'll wrap up the day. All right, so we'll see you in a few minutes.